We're telling a somber story today. As physicians, we are obliged to speak up for children whose health and safety are in danger. Speaking on behalf of my patients, I'm asking for help. But I'm asking for help for myself as well as a physician, because I'm incapable of caring for the health of my patients without the support of the province to help them meet basic needs. What can I do for patients if they don't have food and housing? I challenge you to find a healthcare provider who wouldn't echo these words. But we are busy dealing with the downstream effects of poverty, chronic stress, difficult childhoods. These are the social determinants of health that are responsible for 50% of a person's health, more than environment, more than genetics, more than access to healthcare. And poverty, I believe, is the most important social determinant of health. Neglecting to eliminate poverty gives us a lot of work in healthcare, but this is not the kind of work that I want to do as a physician. My job should not be to clean up the downstream health effects of a government that neglects the implementation of evidence-based, humane, and cost-saving solutions for patients. We are talking about families, allowing families to meet their basic needs of food and shelter. As a physician, by not speaking up for eliminating child poverty, I am doing harm to my patients. Is it too much to say that the government is harming patients by neglecting to act on child poverty? It was a great first step when the BC government eliminated cruel clawbacks this September, but that doesn't exempt the government from neglecting so many other important policy actions so clearly and expertly outlined by First Call. If a trauma patient comes into the ER, I will not save his life by tending to only one broken bone of many. It's a start, but we must treat the whole patient. A little bit of help is not enough when lives and livelihoods are at risk. It makes me honestly very sad when I see the health effects of poverty and chronic stress on children, because it is the tip of an iceberg. Parents protect their children from the health effects of poverty at tremendous cost to their own health. So by the time children are showing the impact of poverty to their doctor, I know that a family's resilience has been seriously weathered. Children are resilient, and they don't often come into our offices with obvious signs of chronic stress until they're older. Treating the late effects of lifetimes of stress is much of what we do in medicine. I would love to prescribe nature walks, sports programs, music programs for kids, all of which combat the impact of chronic stress. But neither parents living in poverty nor our underfunded education system is able to provide that. The usual strategies of medical care simply fall apart in the context of poverty, which is why I need the government's help. Think of a child eating unhealthy snacks that are the cheapest for the family to afford. The last thing this family needs is a doctor demanding that they make healthier food choices. The first thing they need is enough money to afford food. When I did the Welfare Food Challenge last year, I found it impossible to eat on $21 for a week. I made healthy food choices with my $21, but because my diet lacked variety, I ate more of everything. I had constant cravings. I understood how eating on a limited budget could lead to obesity. Imagine giving a patient an exercise prescription for obesity that they developed because they couldn't afford better food, or recreation programs for that matter. Missing the mark like that can cause harm to patients. It is not only a farce, but degrading and harmful for me to prescribe individual lifestyle choices like healthier food and exercise when the problem is systemic. When we trap people in poverty and don't give them the tools they need to stay healthy, when they're healthy, but also when they're sick. Life in poverty is simply precarious. People living in poverty are more vulnerable to illness, and when it strikes, the further disadvantage is catastrophic. People who were barely managing can manage no longer. The despair that I hear from patients is heartbreaking. And yet often the only tools I have to offer are compassion and antidepressant medication. That is no way of looking after people. When patients are marginalized, when they're unable to participate meaningfully in society because they can't afford basic needs, this has an additional health impact. Over 200 international studies have shown that perceived discrimination is linked to every health outcome that has been studied, just like poverty, from heart disease to birth weight to mental illness to proteins in the blood. By turning away from people living in poverty, we perpetuate a cycle of discrimination and stigma that has its own negative health impacts. So is the perpetual power of neglect. I think of a patient with depression who stayed in a toxic relationship because she didn't have the option financially to leave. The children lose out either way, living in a household with marital conflict and stress, or severe financial stress and poverty if they leave. As a physician, again, it is heartbreaking to imagine two different versions of this story of adverse childhood experience. I think of another patient, a single mother who couldn't afford childcare and was forced to leave her job and rely upon social assistance. For her, one of the greatest health impacts of this decision was the social isolation of this choice. And it is unfair to call it a choice, because not using her skills without a family or partner to support her in parenting, and with the additional physical strain of parenting a toddler around the clock with a physical disability and chronic pain, this was not a story of choice. This was a story of disempowerment with a systemic cause, the effects of which are devastating. Chronic stress is the most common problem I see in medicine. Unfortunately, this is further perpetuated by the social services system, which is hard to navigate at the best of times, let alone when patients are sick and vulnerable. It is impossible to overstate how unwilling doctors are to complete the 28-page Persons with Disabilities application form. Removing barriers is critical when patients are faced with multiple challenges. Last year, in 2014, I founded a nonprofit society with colleagues called Basics for Health, which builds capacity in the healthcare system to help patients meet needs related to the social determinants of health, which, as I mentioned, are responsible for 50% of a person's health. It is important to ask if a person can afford to pay their bills, afford prescriptions, if they can afford transportation to appointments. But when we start to help patients deal with the impacts of poverty, what is shocking is the number of hours it takes. Volunteers in our nonprofit society often spend 10 to 20 hours navigating government service support systems, researching eligibility, appropriate services, location, transportation, accessibility, waiting on hold on the telephone. It is overwhelming for our volunteers, it is overwhelming for doctors, and it is overwhelming for patients, especially those facing health challenges, which causes further disempowerment. To help patients meet their basic needs, to eliminate poverty, to make the time to see the tough life stories that underlie patients' symptoms, these are acts of professional responsibility, but also of mutual benefit. And it is my prescription not only for those living in poverty, but for all of us as a society. I'm talking about something more than the money we will save by implementing a comprehensive poverty reduction strategy. I'm talking about respect for one another as citizens. We know that giving produces more satisfaction than receiving. And I often think of the health benefits of that. But population health research tells us the same story when it comes to poverty. The healthiest societies are those with the least income inequality. But what is fascinating is that the wealthiest people in more equal societies are also healthier than the wealthiest people in more unequal societies. We simply all stand to benefit from eliminating poverty. There's no reason to turn away, for our own interest and for the interest of each other. And we can't afford not to lift people out of poverty. The costs of poverty in the form of lost opportunities and livelihoods are tremendous, but in healthcare alone, we pay for it downstream at the cost of $1.2 billion annually in healthcare expenses that could be avoided. The BC government collects more from inequitable MSP premiums than from corporate income taxes. We can afford to eliminate poverty in BC. It is the most economical, evidence-based, and healthy humanitarian decision. And so I call upon the government to answer this question: why not eliminate child poverty in BC? Thank you.